Welcome to everyone, and I want to thank you all for being part of BCBSA's continuing medical education program, where we host learning opportunities on various very timely topics, especially this one. We are very excited to host today's CME on From Prescription to Plate, Implementing Food as Medicine in Healthcare and Beyond. Next slide. So for our overview, the learning objectives, upon completion of this activity, learners will be able to define the core concepts of food as medicine, evaluate opportunities and challenges in supporting and scaling food as medicine initiatives, and review how integrating food into care models can address whole health, improve outcomes, and reduce healthcare costs. This activity is accredited for continuing education credits by the Academy for Continued Healthcare Learning in partnership with BCBSA. Credit is available for physicians, pharmacists, nurses, and case managers. This educational activity was planned and produced in accordance with ACCME standards for integrity and independence in accredited continuing education. Today's presenter, Dr. Kofi Essel, does not have any financial relationships to disclose. Okay, and I just want to introduce Dr. Kofi Essel. Like I mentioned, we're extremely thrilled to have him. He is Elevance Health's first Food as Medicine director. He leads food-related initiatives that work as part of healthcare to treat diet-related chronic conditions such as diabetes, high cholesterol, and hypertension. He and his team work across the organization to drive a holistic view of health that prioritizes access to nutritious and culturally relevant food. He's a board-certified community pediatrician at Children's National Hospital. He's also an award-winning author and speaker and is incredibly passionate about research dissemination and translation. He's been extensively published in peer-reviewed journals, frequently appears in media, and has targeted his messaging for local, national, and international audiences. He earned a BS from Emory University with a focus on human biology, anthropology, and also earned his MD and MPH in epidemiology from George Washington University. I was very lucky to work with him at Elevance, and I really could not be more thrilled to have him speak to us on this extremely timely topic. So I am going to hand it over to Dr. Essel. Thank you.
Excellent, excellent. Jessica, thank you for that introduction. I'm going to go ahead and share my screen and get started. Give me 1 second. So it is my honor and privilege to be here today. It is great to be here amongst our Blues family today, and we have a really exciting conversation that we're going to have today around food as medicine. This is a topic that has really come to life over the last few years, and I think if you haven't heard of it, you will get a good introduction to it today. What we want to do today is give you that introduction to food as medicine and really share with you how it's relevant in your day-to-day work that you do, how it's relevant with the employers you work with, and in your own day-to-day life as well. So without further ado, let's go ahead and get started. Our title for today is From Prescription to Plate, Implementing Food as Medicine in Healthcare and Beyond. So Jessica gave an introduction, but it's only right if I start off with a little bit more about some of the work that I've done in the past. For those who don't know, for many, many years, I ran a culinary medicine program. I was a community pediatrician, ran a culinary medicine program at a local medical school, working with medical students, staff, faculty, community members, teaching them the art of food as medicine for their own lives. And then how do you then talk about it with others as well? So I've seen how food as medicine can be effective. And at the end of the day, a lot of people ask me, why were you wasting your time doing this work? Don't doctors and so many others in this space get the training on this topic of food and nutrition? Why are you wasting your time? And I think that's a great question that you ask me. And I think if we think about the research, when we sort of look back in the past, there was a groundbreaking report that came out in 1985. The National Academies put out a groundbreaking report. And basically what they did, they brought together a group of leading experts from around the country, and they said, let's explore how medical education is incorporating the topic of food and nutrition in education currently, and how we're preparing the next generation of providers to really deal with some of the challenges that we're seeing. So, in this report that was published when all the leadership came together and surveyed all the medical schools around the country, there was a really powerful line that I wanted to call out. This line said this: the committee concluded that nutrition education programs in U.S. medical schools are largely inadequate to meet the present and future demands of the medical profession. This is 1985. They said it's largely inadequate to meet the present and future demands of the medical profession. It said at a minimum, we need to have at least 25 to 30 hours of nutrition education in medical school at a minimum. This is again 1985. So years later, things have gotten so much better. Let me share that with you. So the most recent literature on this topic, what we see is that the vast majority of medical schools fail to meet the minimum number of 25 hours. 71% of schools fail to do that. In fact, a third of schools don't even meet half of those hours. So what we learn is actually current day that there's very limited education around food and nutrition in medical schools. Now, you may say to yourself that that's not that big a deal because after medical school, we have plenty of other opportunities to learn. What about residency? What about fellowship? What about when we're practicing? Providers get this training in other venues. So when we talk to residents, when we look at the fellows, when we talk to practicing providers, they say something quite similar. They say this: we don't feel adequately prepared to engage this topic of food and nutrition with our patients and our families. It's not that patients and families are not asking about this, it's that we don't feel adequately prepared to engage this topic. So it's a very interesting challenge and dilemma, but you also see across the board many providers starting to get more and more equipped on these topics. You have groups like the American College of Lifestyle Medicine, who's really stepped up to the plate and been training clinicians around the country to be able to engage conversations around food and nutrition more effectively, and a number of other groups as well. So this is an important thing that's been brought up, but why is it important? That's a question we must stop and ask ourselves. Why is it important that the next generation or current providers are able to engage this topic around food and nutrition a little bit more effectively? Well, one data point I want to highlight to you came out this year. When you look at US adults, the percent of US adults around the country who have at least one chronic condition, what number would you say to yourselves? So you could feel free to say it in the chat or just in your mind, what number, what percent is that? A lot of people would say maybe 30% or 40%. The latest literature has shown us this number is about 76% of US adults have at least one chronic condition. Now, as one ages, we see that the group above the age of 65, we see that number is about 93% of US adults have at least one chronic condition. Now, two or more chronic conditions, the number is 50% more, it is 50% plus. US adults have at least two or more chronic conditions. So we need to understand that it does appear that the default of life is that all of us will get chronic conditions, especially if we're not dealing with the root causes and not addressing and engaging other root causes as well. But what about specific diet-related chronic conditions such as hypertension? If I were to ask you 1 out of how many adults have hypertension, what would you say? 1 out of 10, 1 out of 8? What if I were to tell you that number is actually 1 out of 2? 1 out of 2 US adults have hypertension. What about prediabetes or diabetes? Again, that must not be as high. So what about 1 in 8, 1 in 6, 1 in 5? What if I were to tell you that this is not the same slide? That answer is 1 out of 2. US adults have either prediabetes or diabetes. And what do we know? We know that many individuals with prediabetes or diabetes or even hypertension have no idea that they have these conditions. So the reality is, again, it appears that the default of life is that we will get these conditions. What about overweight or obesity? We know that number is 3 out of 4 US adults. Now, when you look at the cost on healthcare, what do we see? We see that this number can be above $1 trillion annually. The cost on healthcare as a result of these conditions is higher than $1 trillion annually. Now, what else do we know? If we list out a number of risk factors that lead to premature mortality, what are the leading risk factors that lead to premature mortality? So this study did a great job in doing that. It listed out a number of risk factors, and you can see at the top of this graph that a poor diet, poor nutrition, is the leading risk factor to premature mortality. Not only does it decrease one's mortality, the number of life from years, or years from life rather, but it also decreases one's morbidity, or increases one's morbidity rather, right? So it decreases one's quality of life as well. So we know it decreases mortality. I'm saying that backwards. We know it increases mortality, and we know that it worsens one's quality of life as well. So this is clear, this is consistent, this is something that we need to talk about and have this conversation today. The reality is that food has not really been given the chance it deserves. We don't really highlight food in the way that we can in medicine, in a way that maybe we should. Now, we know that even though it hasn't been given the chance it deserves, it does play a role in medicine. When you look at a number of leading professional guidelines addressing a number of diet-related chronic conditions, you'll see that in addressing these diet-related chronic conditions, second option that we recommend is to start with what? Changing one's food and lifestyle. So we recognize that it is a priority when we look at guidelines and recommendations, but guess what? We tend to not do it as a result of many things. There's very limited time in the clinical settings. Sometimes we don't believe it's going to be effective. And again, the training around these areas are quite poor. And oftentimes we lack the resources to be able to connect families and patients to be able to support them in making these changes. Now, those are true, but there's one other elephant in the room that I haven't highlighted, and I think is really important when we think about the role of food in one's health. We have to understand that food to each and every one of us is a deeply, deeply personal experience. For many of us, food is used or was used as a tool of punishment. For many of us, food has been used as an opportunity to bring our families and our friends together. We cannot have a moment where we gather together without having food present. Food is deeply personal. I love how this study looked at this, the Meaning of Food in Life questionnaire. So this questionnaire sort of asked individuals what food meant to them and then sort of put them in domains. For many of us, food is considered moral. It's a right or wrong thing. For many of us, food is an aesthetic thing, right? Food is all about how things look. And again, I often say this, but for many of us, even watching right now, food should not ever touch. If food touches, it's an abomination. And I know that's how many of us think as well, right? So that's for many of us. Food is all about how it looks. For many of us, food is social. Again, we cannot have social gatherings without having food present. For many of us, food is sacred. It's a spiritual thing. And for many of us, food can be recognized as health. To understand the notion of food as medicine and food in our own health, we have to understand that food means so much to so many of us, and we have to be able to wrestle with that as well. Now, to enter this conversation that we are here to talk about today, it's important to understand that, yes, I started off with understanding or showing you how we don't get a lot of training around food and nutrition in medical school. But the goal of this concept and the work that we're doing is not just to train more doctors to teach about food and nutrition in their 15-minute visit. It's important. That's a role that we try to do in this work. But at the end of the day, the focus here is about changing systems. The focus here is about changing paradigms. We need a paradigm shift if we want to sort of change the course of disease and health for patients, for families, for members, for this country. And what does that look like? Well, this paradigm shift that we're talking about here today is a simple concept we call food as medicine. Now, what is food as medicine? The way we define food as medicine at Elevance Health is simply this. Food as medicine is strategies or interventions that work alongside healthcare, that give access to high quality, nutritious foods and education, focused primarily on three things. How do we prevent? How do we manage? And then how do we treat disease? How do we use food as an authentic tool to work alongside healthcare to prevent, to manage, to treat disease? I'm going to throw even one more thing in there to put conditions, certain conditions at that, into remission. How do we use food as a tool to do that? Under the umbrella of food as medicine, we often talk about diet-related chronic conditions, as we've mentioned already, but we also talk about things such as food insecurity and nutrition insecurity, and we'll dial into those in a few minutes as well. Now, with food as medicine, it's important to understand sort of kind of our theory around that at Elevance Health. We believe wholeheartedly in our bold purpose. We believe our purpose is to improve the health of humanity. And how better yet to improve the health of humanity than using what we call our whole health approach. And you may have seen this image before, but the reality is we recognize that within the four walls of clinical settings, as a clinician, I would love to believe that what I'm doing with my patient and family is really dictating their future in a way that's transformative. And maybe it is to some degree, but we also understand that what's even more impactful is what's happening outside of the four walls of clinical settings, where our patients live, pray, play, sleep, dwell. These environmental circumstances, the social drivers, greatly influence their current and long-term outcomes for the patients, families, and members that we get a chance to work alongside. So for us, we don't want to ignore these factors. And so what we think food as medicine is a double click within this whole health paradigm. Now, within that whole health paradigm, when we think about these other factors outside of the four walls of clinical settings, the one that I want to really highlight on right now is this concept of food insecurity. Now, what is food insecurity? Food insecurity, when all members in a household don't have consistent access to enough food to live an active and healthy lifestyle. Now, what I want you to understand about food insecurity, which you all understand food insecurity as is, but it's important to understand that food insecurity should be understood to be ubiquitous. Every single county in this country is exposed and experiences food insecurity. Not one county is free of food insecurity. For years, I've been working with clinicians and students and residents all around the country in engaging this topic of food insecurity and talking about the role of screening and intervening to more effectively address food insecurity. And it's interesting, when I talk to some of my colleagues around the country, initially the thought is, well, guess what? Food insecurity doesn't occur in my clinic. It occurs over there in that clinic over there, or that clinic over there. It doesn't occur here. I've never seen it in front of me. The reality around food insecurity is also not only ubiquitous, but it's also invisible. When my colleagues started to screen for food insecurity and they realized it was right in front of them, they couldn't unsee it. They realized that families would come in presenting their best because they wanted to protect the identity of their homes. But the reality was, we learned to create a safe environment for families so they could be open and honest about what's going on, so we can connect them to more effective resources, recognizing that food insecurity greatly impacts one's health. What do I mean by that? Well, every year, what the USDA does is they put out this really powerful report. The last report was put out in September of 2024. The next report is going to be put out in October of this year. But this report, basically, the census, they survey about 40 to 50,000 people, and they ask them around the number of questions, around 18 questions around their food insecurity status. And it gives us a good understanding what food insecurity looks like around the country. Now, I must say, as many of us learned in the last 2 weeks, that this report is actually not going to go on any longer after this year. And I will say also that this report has been one of the most impactful reports in giving us insight around food insecurity and also realizing how impactful some of our interventions have been. Now, when you look at food insecurity around the country in the last set of data, what do we realize? We see that 1 in 7 households experience food insecurity. We also see that 1 in 6 households with children experience food insecurity. We see that rates are much higher in Black and brown families. We also see that it's clear that households that experience food insecurity have much higher rates of diet-related chronic conditions. There's a clear association, a correlation between households that experience food insecurity and households that have higher rates of diet-related chronic conditions. So guess what? We should not ignore food insecurity. We cannot ignore food insecurity. Now, it's important to understand data around food insecurity prevalence, but we need to also understand the lived experience for many of the households that we get a chance and we're honored to work alongside around the country. And to do that, I want to introduce to you a patient, and the patient's name is Maria. Now, I want to tell you a little bit about Maria. Maria is a 45-year-old working mother. She has uncontrolled diabetes, and she has some recent experiences with food and nutrition insecurity as well. She has 3 children aged 13, 6, and 4, and she's oscillating back and forth from Medicaid to private insurance. Why? Because of some decreased hours at work and some increased financial hardships. She also lives with her 72-year-old mother who's on Medicare Advantage. So let's talk about Maria's experience. We know Maria has uncontrolled diabetes, And we know that families who experience food insecurity, it doesn't just come out of nowhere. What typically happens is the first thing that occurs is a family will have a sudden financial hardship. And when a family has a sudden financial hardship, the first thing that ends up dropping of the social drivers is one's food budget. The food budget drops. Why? Because one's food budget is so flexible, it's so fungible. We're easily able to adapt our food budget for different times. And so families will oftentimes adjust their food budget. And we oftentimes see that food insecurity is one of the earliest triggers or signs of social drivers of health. And we know that social drivers don't typically travel by themselves. They typically travel with other things, but food insecurity ends up being one of the first things that families may often see. So, how would we describe this experience? Well, what happens is when a family experiences food insecurity, they sort of set off a cascade of coping mechanisms to set off or create some balance in their home. So, let's see what Maria decided to do. So, the first thing that Maria does, like many other families, is she has some food anxiety, a constant perseveration, a preoccupation with where her next meal and her family's next meal is going to come from. Imagine one decreasing their cognitive bandwidth. The ability to shift and focus on many things becomes hindered. Why is that? Because of this toxic, impalpable stress on the brain. So with this decreased in cognitive bandwidth, it's affecting our ability to meal plan, are affecting our ability to get our medications in on time, to get to our appointments. It's affecting our abilities and to do many other things because again, this is a palpable and toxic stress that takes up place in our brain that influences our health. So this is the first thing that families tend to describe. Now, after food anxiety, the next coping mechanism is that the quality of food will begin to drop. And what we typically call that is the diet becomes more monotonous. I call this a monotony of the diet. The diet becomes very simplistic. The family will eat the same foods over and over and over again. Why is that? Because guess what? If I purchase the same foods, I waste less food. Why? Because I know that myself, my family, my children, my mother is going to eat these foods. I'm not going to buy those experimental foods that my clinician encouraged me to buy because I may not eat them, and that's going to increase my waste, which also increases my stress, and my stress is high enough. In addition to that, when the body is when the body experiences increased stress, oftentimes we may gravitate towards foods that are higher in sugar, higher in salt, higher in fat. And in that may not benefit our health in the way that we want it to. So imagine someone with uncontrolled diabetes having an uncontrolled or having poor quality diet. What does that do to their blood sugar? How does that affect their condition, their insulin resistance? We know that there's a direct correlate there that we have to think about. Now, after the quality of the diet begins to decrease, what happens next? I can't cope any longer. I've adjusted the types of food that my family's eating. We're eating the same foods over and over again. The diet becomes very simplistic. No longer can I hold on. I begin to decrease the quantity of food in my diet. And who's going to decrease their quantity first? Adults first, to protect and to guard their children from seeing what's going on in their home. And lastly, the child will decrease their quantity of food as well. Now, the interesting thing is adults always say, my child never knows what's going on in the home. But if you start to do the research and you look at older children, they'll tell you time and time again, guess what? I know what's going on. I don't tell my mother, I don't tell my parent, I don't tell my grandparent what's going on, but I do know what's going on. And in fact, I eat less food so my younger siblings can eat more food as well. So this toxic and palpable stress affects the whole family through this whole journey. And this is an important thing to keep in mind as we realize the importance of how we engage this topic. So this is how I want you to think about food insecurity and stress on the body. Now, stress can do a lot of things on the body, and that could be experienced through food insecurity or a number of things. And to introduce the role of how stress affects our food habits, I want to introduce this concept of emotional eating. And you all have heard about emotional eating, but to throw a definition on for those who may not have heard of it, emotional eating is the practice of eating in response to feelings or emotions such as stress, sadness, boredom, loneliness, or even happiness. So basically, you're overriding your hunger mechanisms and you're gravitating towards foods as a way of dealing with that stress that our body is experiencing. It's sort of, again, it overrides that hunger mechanism. Now, if one has ever been chased by a bear, maybe one or two of us in the room, we know that in that moment when we were chased by a bear, we were not thinking about food. right? So with an acute stressor, a sudden stress, food is not something we oftentimes are thinking about. We're not thinking about our next meal. We're not thinking about our current meal. We're thinking about fighting, probably not fighting the bear too much, but flighting, right? So getting out of there or maybe even passing out. But this is the matter of the fact, right? With an acute stressor, food is not in the picture. We're not really thinking about it too much. But what about with a long-term stress, what we call a chronic stress? When chronic sadness, chronic anxiety, chronic depression, chronic stress, chronic food insecurity, what do we notice about that? Well, there's some interesting patterns that we may see. Now, some of you say, I know what happens when I get really stressed out for long periods of time. I always go to that ice cream, or I always go to eating this. Well, the reality is that may be some of our experiences. For about 40% of us, we experience an increase in caloric intake. For about 40% of us, we experience about a decrease in caloric intake. And about 20% of us, we experience no change in our caloric intake. So the reality of it is that many of us experience different overall experiences, or our bodies react in different ways when we have a lot of stress or more chronic stress. But this is the calories we consume. What about the types of foods that we consume with increased stress for long periods of time? Well, in the literature, what we notice is that we oftentimes will have foods that are more hyperpalatable and very pleasurable and enjoyable. Again, it serves kind of like a pop-off valve for our brain. It gives us a release, right, to consume these foods. When we think about what kinds of foods these are that are hyper pleasurable and hyper palatable, these foods are oftentimes higher in sugar, higher in salt, higher in fat, as we talked about earlier on. We oftentimes will have sort of more binge eating behaviors or disinhibited behaviors when we're consuming these foods as well, with more long-term stress. This is sometimes the experience of many of us. Now, when you think about these foods that are higher in sugar, higher in salt, higher in fat, what types of foods come to mind? Well, one of the things that have been very, very popular in the media today is this concept of foods called ultra processed foods. And for many of us, we've heard of this term ultra processed foods, but let's get into the weeds a little bit more around it. Yes, the federal government has put out some requests, and we're trying to define this more effectively. The reality is the definition is still a little wishy-washy, but there's still some things that we do understand, and we don't need to wait till we fully understand the definition to be able to act, because there are some things that we can do right now. So when we think about the ultra processed foods, or the definition of ultra processed foods and how we define ultra processed foods, I want us to go back to a really interesting and important researcher in this space. I want us to introduce someone named Dr. Carlos Monteiro. Dr. Carlos Monteiro and his research team out of Brazil came up with the NOVA food classification system. And what I would love to do is introduce this NOVA food classification system to you so you can understand how they broke down food processing. So category 1 through category 4. Let's look at category 1 first. Category 1 is simply unprocessed or minimally processed foods. Okay, so just because a food is minimally processed doesn't mean it's quote unquote bad or good or anything like that. Foods are oftentimes minimally processed or processed as a whole. What do I mean by that? So an unprocessed food, think about foods that are coming out of the ground, things that maybe you're picking off of a tree, which again comes out of the ground, things walking on the land, swimming in the ground, swimming in the water, flying in the air. These are just whole foods. Unprocessed or minimally processed are just whole foods, right? If you take a head of broccoli, and you cut it up and put it in a bag, that's minimally processed, right? So the idea of freezing items, the idea of cutting items, of grinding items, these are just minimally processing foods. You're cutting up the kale, you're putting it in a bag, you're cutting up the collards, putting it in a bag and selling it to us. Again, minimally processed. Now, this is category 1. Category 2 is what we call processed culinary ingredients. What do we do there? So we take items out of category 1 and we use these items to cook with. So again, sugar or salt or maybe olive oil, right? The oil, or maybe butter, right? These are items that we may call processed culinary ingredients. Category 3 is what we call processed foods. We mix category 1 and category 2 together, and we get category 3, processed foods. Now, these items, our species has been surviving off of processed foods for generations and generations. So we're not going to demonize processed foods either, but the way we can foods, or if you look at here, you see a picture of sardines. sardines in a can of maybe with some olive oil or some salt, right? Or breads or sauces or cheeses. Some of these are processed foods, right? These are prepared oftentimes with items that you would see in your kitchen, right? These are prepared or cooked in certain ways. And again, we process foods all the time. This is a very common experience. Now, the last category is what we call ultra processed foods. And some people like to understand these foods as foods that are oftentimes made that cannot be made with items in the conventional kitchen, right? So oftentimes these items were more whole foods initially, but a lot of items have been extracted out of them and other items have been added to them. These items end up being cheaper, more cost effective, hyper palatable and pleasurable. Oftentimes fiber and other nutrients have been taken out, other nutrients have been added on. Oftentimes maybe the ingredients used to make them are not very costly, right? Because you want to make more profit for them. So what you're going to do is use cheaper ingredients so you can make more profit from them. And again, there's heavy marketing behind these products as well. They sell incredibly well. Now, if you think about the history of ultra processed foods, we use them to feed the nation and to feed the world, right? They've been phenomenal tools to be able to do that. We've also used them to feed our military, and they've done a great job at doing that. But we may have overcorrected as a country. How so? Well, if we look at how much we're consuming now, we eat the majority of the food that we consume are from ultra processed foods. The majority of food available in the grocery stores are from ultra processed foods. We're eating far too many of them. And yes, they're going to fit into our lifestyle. And at the end of the day, my goal here in our conversation and in this concept of food as medicine is typically not to eliminate them completely if we can. But the reality is, how do we adjust the amount that we're consuming, especially when they're taking over our palates completely? This is an important piece to keep in mind. Now, I love what NPR, they had this picture on their website in this article, and you can kind of see here the breakdown of ultra processed foods. So you can see here an apple, a whole apple, stage 1, unprocessed, minimally processed, still stage 1, a cut apple. You can see here that you take stage 2, right? The processed culinary ingredients, you mix it together, you get apple sauce. And then you have stage 4 items. You have an apple pie, right? That's a processed ingredient. You typically are not using ingredients found in a typical kitchen. And then you have another stage 4 item, maybe an apple gummy bear, right? So again, this apple gummy bear, it's apples, right? Technically, maybe flavors of apple, but it's not a whole food. There's very little whole food in there as a whole in general. A ton of additives, many other things that may actually do more harm than good for our health. So these are ways to think about this. Now, I would love to present some studies to you all around ultra processed foods. I didn't have enough time to introduce them today, but there are a number of great studies that we've seen, randomized control trials, and a number of other observational studies that we've seen around ultra processed foods as a whole. But what I want you to understand is one of the things that we've seen in some of these studies is that we tend to maybe gain more weight after consuming, having an ultra processed food diet and eat more food in general. And the question is, why do we tend to eat more of this food? And there are a variety of things and reasons there. But one of the things that we understand about ultra processed foods, as I mentioned earlier, a lot of nutrients and fiber and other things have been taken out. The foods are much softer. You tend to be able to consume them in a way that may be a little faster. What do I mean by that? Well, here's a really powerful study looking at about 327 foods and looking at the speed in which we consume these foods. And you can see here category 1, again, unprocessed or minimally processed, eating about 35 calories per minute versus the ultra processed food category, about 69.4 calories per minute, double the speed of consuming those foods. So if I'm eating at double the speed, and we all talk about this maybe magical 20-minute window for our brains to realize that our guts are satisfied, we end up eating more food in that shorter period of time, and therefore we end up overeating in a way that we may not have desired to do that. So simply changing the processing of one foods, we see that many people end up eating less foods and eating more nutritious foods at the same time. Now, well, what else do we understand about this? Weight is one thing, and weight is a very complex conversation, and we can get into that. But there's a number of other things that we need to talk about around ultra-processed foods. We understand that some of the factors, maybe the additives incorporated into them, maybe the packaging that they're a part of, maybe the waste, certain items have been removed from them, the lack of polyphenols, the lack of other nutrients that are feeding our microbiome, the list goes on and on. they create more inflammation, or they're rather associated with more inflammation in the body. They're associated with more what we call dysbiosis, or more of a harmful microbiome, or the bacteria in our guts. They're associated with more what we call oxidative stress, insulin resistance, increased blood pressure, increased disease states such as type 2 diabetes, cardiovascular disease, all cause mortality. The list goes on and on and on. We see a clear association with these conditions. So we know that with individuals, when they experience food insecurity, they gravitate towards more ultra processed foods. But this experience of consuming more ultra processed foods doesn't just affect those experiencing food insecurity. And food insecurity is also part of this conversation. Another part of this conversation has been introduced most recently in the last few years, is a conversation around this topic of nutrition insecurity. Now, what is nutrition insecurity? Nutrition insecurity basically is a complementary conversational piece around food insecurity. So it takes food insecurity and thinks about the quantity of food people are consuming, and also thinks about the quality of food that individuals are eating as well. And why is it important to think about the quality of foods, and that foods are meeting people's cultural needs as well? Well, it's important because we know that the majority of foods that we consume are from ultra processed foods. We know that majority of foods available in the grocery is from ultra processed foods. We know that only 1 out of 10 adults consumes ultra processed, or consumes enough fruits and vegetables rather. And as a pediatrician, I can tell you that only 1 out of 10 children consumes enough fruits and vegetables as well. So there's a huge gap there. And this is an opportunity, if we think about food insecurity and nutrition insecurity, that we can use food as medicine as a very powerful and important tool to be able to engage. Now, for us at Elevance Health, we have a strategy in how we think about food as medicine. And I want to introduce to you how we think about it, our strategy, and how we engage this topic. So our strategy is built off of 3 major pillars. Our pillar number 1 for our strategy is implementing food as medicine throughout our health enterprise. Through commercial, Medicaid, and Medicare. We want to make sure that food as medicine is not allocated and relegated to just one line of business. We recognize that, yes, food as medicine affects individuals experience, or we can use it for individuals experiencing food insecurity, but food insecurity, again, affects all lines of business. We also recognize that at the end of the day, that disease, chronic conditions, are affecting everyone around the country as well. So we want to make this a tool that all of our lines of business can access. Number 2, we recognize that we want to advance a digital-first approach to food access and education, no matter where our members, patients, families live in the city, in the zip code, in the region, in the county, in the state. We want to make sure that our members can access high quality food and also quality education that meets their needs as well. And last but not least, we love to think about this concept of advocacy. How so? We want to advocate for health system-wide changes, again, paradigm shifts, to build awareness of how food impacts health. How do we do that? We're trying to do that through a number of things, through our thought leadership, through our education and research, and even public advocacy as well. So we're doing this in a number of different ways because we recognize that at the end of the day, this is a powerful tool that can be used to improve health outcomes. So for us, when you think about food as medicine, for many of us, you've seen this food as medicine pyramid. This is sort of our design of that food as medicine pyramid that was ultimately or originally designed by a team out of Massachusetts in 2019. So with this food as medicine pyramid, you can see there are 6 different approaches that are typically used to engage patients and families around tools using food as medicine. So these are 6 different tools that you can use. And let me break them down really quickly. With this pyramid, on the left side of the pyramid, you can see at the base of the pyramid are techniques that use prevention. At the apex of the pyramid, you can see techniques that use treatment, or are used more for treatment. So at the apex of the pyramid, the first thing I want to describe is what we call medically tailored meals. Medically tailored meals are pre-prepared meals designed by a chef and dietitian, designed to give you 50% or more of your calories for the day. They're typically delivered to the home, and they're ready to heat and eat. Right? So you can think about this for an individual who's recently left the hospital post-discharge, and we know that malnutrition or having difficulty accessing food or consuming food could be of the leading causes for getting patients back into the hospital. So how could we help that? Well, one of the ways is by providing medically tailored meals for a period of time. You can also use medically tailored meals directly to support individuals maybe experiencing other disease conditions as well, maybe more extremes on disease conditions as well. Thinking about individuals who may have a high hemoglobin A1C who have diabetes. So you may want to use it as a tool to help them manage their condition and help teach them some tools with that as well. Maybe individuals having significant blood pressure that can't get it under control, HIV, we can think it for, we've used it for that as well. And for a number of other conditions, chronic kidney disease, and list goes on and on as well. Another tool we often use is what we call medically tailored groceries. Medically tailored groceries includes things like produce, fruits and vegetables, and other items as well. Whole grains, nuts, fruits, vegetables, seeds, legumes, protein rather. A number of items that can either be delivered to the home, tailored by a dietitian, delivered to the home, picked up at the grocery store. You can give sort of a card that families can use and have sort of limitations on that card so families can purchase items that are designed to improve their health around their diabetes, their high blood pressure, around improving their maternal health, or whatever it may be. Group 3 is what we call produce prescriptions. These are simply produce, right? Fruits and vegetables. It can be fresh, it can be frozen, it can be canned. They can be delivered, they can be picked up at the grocery store. You can work on with your local farmers, working with local CSAs, local food hubs. It's a great tool to be able to improve health outcomes as well. Why is that? Well, what do we know about produce? We know, again, only 1 in 10 adults and 1 in 10 children consumes enough fruits and vegetables. So what we've seen in the literature is if you simply provide a little bit more produce, you can see how that can improve health outcomes as well. Number 4 is what we call public nutrition security programs. We know about these: SNAP, WIC, school meals. These programs are powerful. They're effective. They're tried and true. We understand them to be tools that can decrease poverty, decrease food insecurity, improve health outcomes, decrease hospitalizations. The list goes on and on and on. Number 5 is what we call population community level healthy food policies and programs. Food as medicine should never eliminate the local food infrastructure. We know that the reason food as medicine is where it is today is because of phenomenal organizations on the ground who've been doing this work for many, many years. And that is an important piece that we cannot eliminate. So working with our local food banks, our local soup kitchens, our local food pantries, working with our local organizations, doing community cooking classes or whatever they may be, are really important in this movement as well. And last but not least, number 6, personalized, empathetic nutrition counseling and education. Many of us have heard of things like the blue zones, recognizing that healthy eating doesn't have to look the same way wherever you go. It doesn't just have to be that sad, simple salad that you eat and are sad about, right? It doesn't have to be those rice cakes for breakfast, lunch, and dinner, or whatever it is in our minds. It could be culturally sound, meeting a number of different taste preferences and palates, and it can be really tasty and enjoyable and nutritious foods as well, right? So we just have to keep that in mind and not make this a boring experience. At the end of the day, food means so much to us, and we should not take away that joy of food when we talk about education and meeting people where they are. So this is the pyramid around food as medicine. Now, the top 3 approaches that people typically talk about are medically tailored meals, groceries, and produce prescriptions. These are the core around food as medicine. And typically what you'll see is that medically tailored meals are going to be the more expensive option because, again, they're pre-prepared. The more preparation that's needed there is going to increase the cost. But they're quite effective. There's a lot of literature around medically tailored meals. Some of the most robust literature is built around medically tailored meals. But all of these interventions have literature around them. Now, what do we know about these interventions? We know a lot about them, and I'll list off some of the things that we've learned about these different kinds of interventions. But there are still a lot of questions we have to ask, right? There are questions we're asking around, how much food should we be providing? For how long should we be providing these foods? Should we be covering other people in the home and supporting other people in the home as well? Should we make sure, what's the amount of maybe dollars we should be putting on a card? We're also asking questions about what do we do after our program ends? Should we be transitioning to a different program? Should this program go on in perpetuity? Right? We're asking some really important questions, and these are questions that a lot of our colleagues around the country are trying to understand and running the necessary programs to be able to learn from our families and seeing what's working, what's not working with them around the country as well. So some of the literature, some of what we've learned about these studies is that these programs have been shown to be associated with decreased ED visits, hospital readmissions, improving dietary intake, improving blood pressure and A1Cs and overall health status and mental health risk and food insecurity, and the list goes on and on and on. We see it time and time again in the literature. Now, this is an important thing to understand. Our team at Elevance Health, we work with a number of other providers around the country as part of the Network of Excellence. The Network of Excellence is a group that has been started by Tufts University and along with another payer provider that came together to say, hey, how can we really move some of this great work forward that a lot of us have been prioritizing within our organizations? So this has been an exciting opportunity for us. And in this, what you can see here, this is a report published by the Aspen Institute. You can see here there are many different ways that people have been using food as medicine around the country. Again, type 2 diabetes is one. You can think heart disease, a number of different types of heart disease, chronic kidney disease. You've seen people use it for liver conditions or osteoarthritis, for HIV. We've seen people use it for high-risk pregnancies. We've seen it for gestational diabetes, postpartum as well, right? So there are a number of things that we're using it for, that we're working alongside patients and families for. And let me say this here, because I haven't mentioned this yet. I'm not saying in any form or fashion we need to ignore medications or never use medications or prevent them at all. In fact, food as medicine amplifies the effects of medications. Sometimes we're using them before medications. Oftentimes we're using them with medications. But at the end of the day, we want to recognize this as a viable and palpable tool that can be used to work within healthcare to improve patients' health outcomes as well. Right. So let me give you a practical example as I land the plane. So I'm going to land the plane with this. As the Blue Cross associations, as organizations here are doing some phenomenal work in doing this work within your different entities, we want to make sure to talk about what does it look like to work within private insurance. And I want to give you a case study around that. So one of the reports, a white paper that we were able to support in its preparation and publication, was a report done by the Milken Institute. It was called A Blueprint for Employer-Led Food as Health Strategies. This is a really powerful report led by Holly Freistadt and her team at Milken Institute. Now, this report, I'll talk about some of the things that we talked about in this report in the next few slides, but I think it's important to understand the role of private insurance and how private insurance can play a role in using food as medicine to impact health outcomes. What do I mean by that? So first and foremost, let's look at the insurance paradigm around the country. In 2023, we saw that about 92% of people had health insurance. All right. When you break down health insurance today, what do we see? We see about 65% of that is private insurance, and about 36% of it is public health insurance. And we know that the majority of the health insurance across the country is employer-based health insurance. So we see about 53.7% of Americans, or more than half of Americans, are covered by employer-sponsored health insurance. What else do we know? We know that in the U.S. workforce, it's over 163 million active employees. What is this telling you? That in the workplace, there's opportunity that exists in the workplace with employees to be able to engage them by using food as medicine. We've seen in the literature that actually engagement has gone down. We've seen less engagement with workers and workplaces. And one of the things that we recognize is that there are tools that we can use to be able to support that. So we recognize that the employer-sponsored health insurance world is a wonderful environment to be able to potentially use tools as we're talking about here. But what do we also know? We know that there's not very much data in the privately insured populations. We see a lot more literature in Medicare or in Medicaid, but not as much in the commercially insured population. Not to say it doesn't exist, and not to say it's not effective, but there's less data there. We also know that chronic conditions take a toll on employees. It decreases the well-being of employees. It drives absenteeism. It drives increased healthcare costs and even utilization of healthcare costs as well. We oftentimes, again, think of food insecurity as allocated to certain parts around the country and to certain populations. But what we also understand is that a large number of people who are full-time or part-time experience food insecurity as well. 66% of households experience food insecurity have adults who are either working full-time or part-time. We also recognize that employers, they have a lot to balance when it comes to working with their employees and really trying to manage costs in the workplace. They have to manage things like healthcare cost containment, the employee experience, satisfaction, engagement, productivity and performance, morale and retention. All of these things are areas, the values of the workplace that employers are really working to balance. And for us who are our payers, who work with employers, we get a chance to work with them and helping them to design interventions and strategies to support their employees in a number of different ways. The other thing I think is really important is that typically the conversation around food and food as medicine is really thinking about the return on investment. But to do this work well, especially in the employer-sponsored world, we need to move the conversation to value on investment as well. Again, thinking about things like retention, things like morale, satisfaction, engagement in the workplace. These things are critical, and we cannot ignore these things when we think about working with employees. So in saying all of this, what I really want to get across is that food as medicine can be a powerful tool to support the value on investment in the workplace for employers around the country. And we, as payers, get a chance to work with them and support them in these efforts. I want to give you one last example as I land the plane. So one last example, we've been doing this work for a little bit of time, and we believe, again, wholeheartedly in food as medicine. And what we've seen is that there's a strategy that you want to use. And the Milken report talks a lot about this as well. But in general, when you're thinking about working with employers and implementing food as medicine in the workplaces, you want to start off with thinking about what are the needs and resources, not only for the employer, but also for the employee, right? What resources are local in that community, whether in that state, whether in that region, whether in that county? What resources do they have in the workplace? Do they have a kitchen? Do they have a vending structure? Do they have a sort of a cafeteria environment? You want to think about those things. Even for employees, what kind of conditions are they maybe struggling with? Are they struggling with certain diet-related chronic conditions? Do they have a certain demographic? Do they have children? Do they have a lot of children? Or is this an intervention you need to think about the children in a home as well? Are the individuals in the home an older population, right? You got to think about all these things as well when you think about designing and working with an employer to design the right kind of food as medicine strategy. The second thing we often think about is making sure you think about, do you want to use a sort of a general wellness approach or disease-specific design? So do you want to go with more of a preventive design that everyone in the workplace can access, right? That all of us can experience the benefits of food as medicine in that kind of way, or maybe disease-specific, maybe addressing diabetes directly, or maybe addressing post-discharge directly, or whatever it may be. You can think about that as something that may be important depending on the workplace, depending on the employer that you're working with. Number three, we want to think about identifying the right partners. There are phenomenal partners and vendors out there around the country, whether again, local community partners and vendors and organizations, or maybe even national partners and vendors and organizations, or regional partners and vendors and organizations. You want to make sure you're partnering with the right group to deliver what you need for your employees at that place. Number four, we think about building a culture of food as medicine as well. Now, what do I mean by building a culture of food as medicine? I mean that to implement food as medicine and assume that just you come in there, you put a program in place and everybody's going to sign up for the program, it's going to be an uphill battle. You have to start with building a culture. A lot of what we've talked about is doing things like lunch and learns, starting to implement some of these strategies slowly, right? Maybe even thinking about affecting some of the items in the cafeteria. And again, not bringing in bland, tasteless items, but tasteful, enjoyable items that just so happen to be good for you as well, right? You want to think about these kind of processes and take your employees through that journey. Number five, we think about prioritizing effective recruitment strategies, whether that's working with special interest groups or resource groups on site, whether that's working with using testimonials from your own employees. These are the kind of things that are very effective as well. Number six, we talk about implementing the intervention effectively. And last but not least, we talk about evaluating the findings. Not only evaluating the findings with quantitative data, but also qualitative as well. asking questions, talking to members, understanding their lived experiences. Is this effective or not? Understand the value on investment. Is this working? Is it not? What's valuable for them or not? We believe wholeheartedly that food as medicine can play an important role in improving health outcomes to prevent, to manage, to treat diseases, even putting conditions into remission. And we hope that you learned a little bit today and will start to consider implementing them in your workplaces as well. I want to thank you for your time.